Hi, everybody. Welcome back to the Faculty Factory podcast. I'm Kim Skorupski looking at Dean Sanchez. Hi, Dr. Sanchez.
Hi, Kim. How are you?
I'm great. Thank you so much for being on the Faculty Factory podcast, folks. We're talking today with Dr. John Paul Sánchez, MD, MPH, just celebrating his 1 year anniversary. He is the Dean of Universidad Central del Caribe, which is shorthand UCC, the School of Medicine in Puerto Rico. So congratulations on your 1 year anniversary, Dean Sanchez. That must have flown by.
Excellent. Thank you so much, Kim, and very good pronunciation of our school. It's so important to acknowledge the history of the school. We'll be celebrating our 50th anniversary in 2026. So I've felt really honored and privileged to have been afforded this position at UCC.
Wow. And so tell us a little bit about Puerto Rico and the schools of medicine and the universities there and the campuses and the unique nature of the treasures down there, because I think a lot of us need some education. Where is Puerto Rico and tell us more.
Yeah, no, absolutely. It's always an honor and a privilege to talk about Puerto Rico. I identify as Puerto Rican and New York City, Nuyorican. Both my parents were born in Puerto Rico and migrated to New York, where they grew up and eventually met each other and were married and had myself and my brother raised both of us in Bronx, New York. So I'm a proud Bronxite. It was a great place to attend school, not only elementary and high school, but also medical school. I attended Albert Einstein College of Medicine, did residency there. And then after residency, assumed my first faculty position within the Department of Emergency Medicine at my alma mater. And, the idea now to go full circle, to return to Puerto Rico, where my parents were born, and serve in the capacity as a practitioner and as an educator, more importantly, as an educator and administrator, is really a dream come true in a great way to honor the legacy of my parents. And it's been extremely fulfilling. As you mentioned, there's 4 medical schools in Puerto Rico. Puerto Rico, some may not know, but PR became a part of the United States after the Spanish-American War in 1898. And since the early 1900s, individuals born on the island are U.S. citizens, which distinguishes individuals of Puerto Rican ancestry from other Hispanic Latino groups, because we are really the only Spanish-speaking country that individuals on the island and born on the island have citizenship status. And so, our 4 medical schools primarily consist of individuals who grew up and were raised on the island, are primarily U.S. citizens, speak 2 languages, because even at a very young age here in the island, students are trained in English and in Spanish. And that tradition is carried out in our 4 medical schools. Of the 4 medical schools, one is private, UPR, the University of Puerto Rico, which is the oldest medical school. And it's actually celebrating its 75th anniversary in 2025, and we'll all be coming together to celebrate their great success. And then 3 private schools, and I serve as the dean, as you mentioned, at Universidad Central del Caribe, which is the oldest private school in an area called Bayamón, Puerto Rico. We have 77 medical students under the School of Medicine. I oversee our biomedical sciences program as well. And we have currently 17 PhD students doing incredible basic science work. So it's been nice to be able to support both pathway of students. And the thing that I marvel at every day, and I wish I had myself in medical school, is seeing and hearing the students interchange between English and Spanish. And it's not only English and Spanish, but their competency in medical English and medical Spanish. That's been really fulfilling. So that's a little bit of my journey and where I'm at currently.
I love the word marveling. It's such a beautiful, rich word, and I appreciate that. And I love when I see leaders whose eyes light up describing something. And that marveling nature, I think, is what makes Puerto Rico such a gem.
Absolutely, absolutely. I think, faculty and learners were always thinking about how to document or create scholarship based on our daily lived activities and experiences. Being here has inspired me to think about how I could bring to light in the literature the journey of bilingual education in Puerto Rico across the 4 schools, and how our graduates uniquely fill a workforce demand for the mainland. We're living at a unique time. When I was born in the 1970s, the Hispanic population was about 5% of the U.S. population. And between the 1970s and today, it has grown nearly 6-fold, where individuals of Hispanic or Latino identity, or LHS plus, which is an umbrella term I use, represents 20% of the population. So now is the largest non-white racial ethnic population in the United States. And uniquely, many in the community are Spanish dominant, bilingual. A huge proportion are still English. But when we think about providing accessible care that's linguistically appropriate, it is developing a workforce that has competence in medical Spanish and medical English. And I think that Puerto Rico historically has provided a large proportion of practitioners to fill that need, and even more so has an opportunity to not only have some of their graduates step into the States, but put forth models of bilingual education for medical schools in the States to adopt and consider.
Well, Dean Sanchez, that's exactly what I was thinking. So thank you for highlighting this component. And I think what made me think, as a sociologist and someone who's steeped in program evaluation and just kind of being involved in community-based efforts and community-based participatory research, I'm thinking that the population that we're talking about is so rich and has such depth and expertise, but it's kind of localized and there's very little awareness of, and you have graduates pop here and pop there. And as you mentioned, the proportion of, the population is expanding, but how do we diffuse that more broadly so that it becomes normalized, that these role models, that people can see themselves in their care providers, how can we expedite or make sure that is, I don't know what I'm trying to say, that's more translatable or that's more accessible? I mean, am I making any sense? Do you kind of get what I'm saying?
Well, I think you're bringing up a lot of great questions, right? I think that we know that hospitals, if they're going to receive federal funds, need to provide linguistic care to patients. That usually exists through interpreters, whereby if a practitioner is unable, or team members on the team are unable to speak with a patient in their first language, and here we're speaking about Spanish, that an interpreter is available in person, by camera, or by phone to enhance communication so that the patient understands their condition, what's going to be offered to them during their stay, and what comes next after discharge. But for many individuals that are bilingual as practitioners, we can see the difference in terms of the use of an interpreter versus having direct communication with someone who is a non-English speaker. Direct communication between a practitioner and a patient without a third person just gives a different level of empathy and compassion that doesn't exist in the same way with an interpreter. And so I think there is this hope that we can increase the number of practitioners that speak more than one language. But that's going to take effort. And that's going to take resources. And so when we think about the resources to really develop more bilingual practitioners, it's multifactorial. We need to have develop teaching and learner assessment materials. In Spanish, there's a lot of teaching materials to introduce medical Spanish to learners, whether it's a beginner, an intermediate, or an advanced. In some of the other languages, that material isn't as readily available. When I think about the languages spoken by Native American tribes, right? The resources may not be as much. But when we think about Spanish, one is having the teaching and then the learner assessment materials, because we want to show that people are achieving certain competencies, milestones and competencies to receive a certificate or be able to practice on their own without the use of an interpreter. And some hospitals are starting to incentivize when a practitioner is able to speak a second language with a patient. So Kaiser Permanente, some of the hospitals in Texas have provided bonuses to practitioners who see those patients on their own. But even separate from having the teacher and learner assessment materials, as a part of the infrastructure, you need faculty. Faculty who are going to develop their peers, other faculty who are going to teach and evaluate medical students and residents and fellows. And so, as we know, only 5.5% of current faculty at our allopathic medical schools identify as Hispanic Latino. Now, those aren't the only faculty that are bilingual in medical Spanish and medical English, but a large proportion come from that pool. And so if we're hoping to meet the needs of the 20% of our patient population, then we really need to consider, how do we increase the number of Hispanic Latino practitioners who become faculty and help them maintain their bilingual identity, which is a big question. Does that come under an Office of Faculty Affairs? Does that come under Career Development? Does that come under Office of Medical Education? But without accountability or including it in a strategic plan, nothing changes. And so this might be an important discussion for our faculty affairs leaders and officers.
All right. Thank you for saving me, JP. That was very eloquent. And I can't believe you got to what I was trying to ask with that rambling train of thought, because that's exactly, I was heading toward the faculty experience, because to me, it's very clear what a community can gain from having practitioners who look like them, who understand them. It's very clear what the patient experience is like. And I can't help but reflect on colleagues and early career faculty that I've been coaching who are not of mainstream, and they go in the middle of Iowa or Kansas somewhere, and they're the only one of fill in the blank. And that is can be incredibly isolating. And it's an honor and a privilege, a blessing, but also a curse when you're the only one of something in any kind of a community, because the sense of this tremendous burden of carrying the weight of, I'm the only, say, woman here. It's so stressful in academic health anyway, but you add these other layers of stressors and tension points. And that's what I'm wondering how we can support, and you brought us nicely to that. How can we as institutions wrap around resources and programs and policies that not only entice faculty who look like our community and our patients, but keep them there, support them. And that's why I love your BNGAP, the Building the Next Generation of Academic Physicians. Again, folks, that's BNGAP, Building the Next Generation of Academic Physicians.org website. When Dr. Mike Barone, the reason why Dr. and Dean J.P. Sanchez is here, because Mike Barone, president of the American Pediatrics Association, told me about you and told me about your work, American Board of Pediatrics, pardon me. And that's what I think, to me, in my field of faculty development, I'm looking for ways to support the total, be inclusive of all faculty. It's reminding me also of efforts underway to support faculty who have disabilities, for example, need some visual support tools on their monitors, or who have need special hearing aids or special modifications for hallways and restrooms, that we've done a good job historically for students, and yet we were surprised to realize, oh my gosh, we didn't really have a lot of policies or programs or resources or support baked into budgets to support faculty who had disabilities. So I'm wondering how we again take and leverage this wealth of talent, and not only again recruit talent, but retain talent and build infrastructure to make people feel like they're absolutely are valued and should be there and they belong there. So that's kind of what I'm getting at. And I'm always curious how you thread that needle.
You've probably had many speakers who have shared the scope of their Office of Faculty Affairs. Faculty leaders undertake different aspects. Some focus more on onboarding. Some also include in their scope promotions or career development. One area that I've always really been passionate about, which ties to, just my way of giving back, is how can we diversify the academic medicine workforce as much as we've spoken about diversifying the clinical workforce. And so historically, many offices of diversity, equity, and inclusion have focused on diversifying our student body for the purpose of diversifying our clinicians, our practitioners, our family medicine doctors, our internists, or psychiatrists. An area that has been spoken about, but there hasn't been a lot of structured efforts, has been the concurrent pipeline, which is how do we diversify our educators who teach our students on a daily basis and create curriculum? How do we diversify our researchers who are conducting basic science, clinical research, translational research in our medical schools? How do we diversify our administrators, our chairs, our deans, our directors, who have great influence over strategic planning and budgeting that impacts often the communities where the medical school sits in? So for me, as much as I have been a product of pathway programs designed to diversify the clinical workforce, I've concurrently aspired to be a faculty member and have been particularly interested on what we need to do to diversify the academic medicine workforce, which is really our faculty and senior administrators. Back in 2008, and sitting with some mentors and listening to their challenges as women, individuals who identify as women of color, LGBT individuals, and other individuals, minoritized and underrepresented within academic medicine, a group of us decided to start an initiative titled Building the Next Generation of Academic Physicians Initiative, which has subsequently become its own 501c3 organization. In our initial investigative work, what we came to realize is that, one, really there was no research around this, or research was lacking around what were the facilitators and barriers to minoritized individuals thinking about, considering, and succeeding at becoming faculty. But, when we did our analysis of both individuals that were historically minoritized and individuals who were not, really there was a dearth of information for everyone. So what we came to find out is that pre-faculty, and what we call now as pre-faculty development, didn't exist for anyone.
Right.
But what we do in terms of pre-faculty development needs to be nuanced for different individuals based on who they are, what they're seeking at the moment, how they want to grow. It's very personalized and learner-centered, just like when we provide clinical care, it's patient-centered. So we view pre-faculty development through BINGAP as being learner-centered. And when we think about the learner, it's really looking at them through a holistic framework. I'm grateful to have worked with colleagues from across academic medicine, clearly from offices of DI, but also offices of student affairs, offices of GME, office of faculty affairs. Because when we think about pre-faculty development is not limited to when you're a medical student. It's not limited to when you're a resident. It's really a longer journey until you get that first contract in your hand. And as such, BINGAP has created educational materials now for college students, post-bac students, medical students, residents, and fellows. And even faculty view the information as valuable as they frame how they're going to have success because they were never provided it, right? So we don't base our milestones and competencies by whether you're a medical student or resident, but really, are you a beginner? Are you intermediate or you're advanced? Because we're learning that really everyone can benefit, even those people with already a formal contract.
Thanks, JP. So, knowing, your depth as being an educator, a researcher, clinical care, community engagement, and calling out your at least two books, Springer books. One is Succeeding in Academic Medicine, a roadmap for diverse medical students and residents. The other one is Health Professions in Academia, how to begin your career. You wrote that racial and ethnic minority groups can lose interest in academic medical careers during medical school and others during residency. So, talking about the stages at which people lose interest. And that kind of stuck with me. And it's made me think about, the projected and estimated shortages of the healthcare workforce, coupled with how, tough we know financial and funds flows are and RVUs and how to pay for healthcare. And these just seemingly endless pressures on faculty, healthcare providers to do more and still have a research career. I'm wondering, if you could talk a little bit about this idea of losing interest and where you see this newer generation coming up. Where are they losing interest, or are they kind of regaining it? How can we shift? What can we do as leaders to kind of regrow that interest or maintain that confidence in us as an industry? Any thoughts? I know it's a kind of a big, wild question, but when I read that you wrote that and when you discovered that in one of your papers that really kind of stuck with me. And I thought, gosh, somebody's started out and they lose interest. How does that happen? I have some ideas, but just kind of curious where you think we can go to remedy that.
Yeah, no, thank you, Kim. I think that was an important finding. It wasn't a finding that BINGAP, a finding of BINGAP, but actually from Dr. Angelo and Dr. Heffy in this paper that they wrote. I believe the title starts with Reaping What We Sow. And they looked at data from the matriculating student questionnaire and from the graduation questionnaire to see if different racial ethnic groups had a different level of career interest on starting medical school and on graduating. And what they found is Black, Hispanic, and Native Americans on starting medical school, a lower proportion reported interest in an academic medicine career, serving as faculty or a senior administrator. And through the graduation questionnaire, the proportion was even lower, right? So, on starting medical school, a lower proportion of those historically minoritized were interested in academia in comparison to those who identify as white. And then the proportion was even dropped further. And so, one of the natural questions is what's happening during medical school if interest in becoming faculty in it or administrators decreases over 4 years. And there's other research has shown that interest in academia doesn't rebound during residency. So whatever proportion you have at graduation continues on or further diminishes. And I think there's a lot of factors that contribute to, or, some people, Dr. Higginbotham, who used to be the lead diversity officer at the University of Pennsylvania, did this great modified framework that built off of social determinants of health to social determinants of academia. And what are some of the factors that contribute to people considering faculty careers or staying within the faculty ranks? And it has to do with the physical environment and the social environment and policies and processes and so forth. I think for medical students, some specific examples is, if you don't see people with similar lived experiences, do you really feel like you can follow in that footstep? If the faculty member, the educator, isn't bringing into the classroom what you experience or what you have experienced on a day-to-day basis, and that's how you want to carry out your life talking about those topics, then a medical school setting, you may not view that as the best place for you after medical school. And then, of course, we know based on the research that Black, Hispanic, and Native American faculty, and also women, it takes them longer to be promoted from assistant to associate and associate to full. And when students hear about that experience, some people are just turned off. Why would I want to work just as hard or harder, not have a space to share my lived experiences, and not be given equitable success in the process? And so, for that, I'll focus on being a clinician and not assume the role of a faculty member and not have to deal with that second stressor. So I think it's multifactorial. Those are just 3 examples. But what we've tried to do is work with organizations like the Latino Medical Student Association, which is the oldest and largest medical student-driven organization dedicated for Latino advancement, the Student National Medical Association, similarly for the advancement of Black African American physicians, APAMSA, for the advancement of Asian physicians, ANAMS for Native American physicians, to understand how our students are feeling today about becoming future faculty and modifying our teaching materials to better engage them, and to help them understand that, yes, they can have pre-faculty success and eventually faculty success.
Yeah, this is great, JP. And we haven't even begun to talk about, in this conversation, basic scientists. I mean, you talked about, you've got, PhD programs and what's going to happen with the future of investigators and at the bench and at the bedside in the clinic doing research. What is the motivation? We go into academic health systems to do basic research when you see your faculty members also struggling with grant funding and scholarship and trying to secure their salaries and build their labs and maintain their labs and get equipment. So it is a very definitely multi-layered. Dean Sánchez, again, I want to congratulate you on your 1-year anniversary. And looking back, would you like to kind of share any tips or lessons learned or wisdom or something as you're kind of wrapping up the year here, thinking about, wow, I can't believe all that's happened to me. I'm wondering, did you ever think that you'd make that whole full circle of life journey back to Puerto Rico? And how are you thinking about it? How are you feeling about it? And maybe what's in the future for you?
Yeah, I'm so grateful and honored to have been afforded this position. It's really been a dream come true. I've always thought about living in Puerto Rico and being able to live and also have this professional opportunity is the perfect mix and blessing. I think that it came at a good time. I think I'm fortunate to live at a time where the Latino community is now 20%, that there is greater respect and understanding of the value of being a bilingual practitioner, which hasn't always been the case. Historically, speaking a second language or your first language being other than English was viewed as a deficit. I think now institutions and the federal government is valuing speaking more than one language, which is a change in American culture that shows great value to it. And so being able to step in this role at the current state of affairs, is a unique opportunity for me to work with colleagues to think about how we can extend this curriculum that has been a part of Puerto Rico for nearly a century, and thinking about how medical schools in the mainland can adopt and adapt it to create more medical Spanish and medical English practitioners. And so through efforts through the Latino Medical Student Association, we've received grant funds from the Josiah Macy Jr. Foundation and the Commonwealth Fund, the National Hispanic Medical Association, and private donors to start the process of developing the first bilingual medical Spanish, medical English campus in the mainland. And for me, why it's so meaningful is because that's what I had hoped for myself, to be able to attend a medical school where I could learn in that fashion in two languages day to day to serve the patients of the Bronx. The Bronx, it's about 50% Latino, with a huge number being bilingual. And I can't think of a better way to give back than to allow students to stay in their community, their neighborhood, develop in a way that they value based on their lived experiences, and to really achieve health equity through a bilingual lens. So it truly has come full circle, not only in being in Puerto Rico, but then being able to now take this incredible asset created in a system, a structure created in Puerto Rico, and extend it to the States is something that I'm looking forward to do as a dean over the next couple of years.
Oh, Dean Sanchez. So that's it. That's the answer. Not necessarily only bringing people into a community to, here I am to save the day, and I'll be your savior, and I'll help you, and I'm going to drop myself into your world, but raising the leaders from within. So now we're empowering people who are already there. We're not going to bring in some consultant. We're going to grow our own consultants right here. And so that's the answer. And I love that. And thank you so much for your education, for helping us understand and learn more and appreciate, and for sharing your wisdom with us. And folks, this is Dr. J.P. Sanchez. And check out the website, the BNGAP. Go visit UCC School of Medicine, Puerto Rico. And again, congratulations on your 1-year anniversary. And thank you so much for being on the podcast, JP.
Thank you. It was a great honor, Kim. Thank you so much.
Hi, Faculty Factory podcast listeners. I'm Kim Skorupski. I want to share a great opportunity with you. We've created a faculty leadership collaborative of faculty affairs and faculty development leaders from around the country, and we're offering a leadership boot camp in January. This one is for early career faculty members. That is, faculty members at the instructor or assistant professor rank for about less than 5 years. The boot camp will be 3 hours a day for 3 consecutive days. So specifically, it'll be January 14th to 16th. That's a Tuesday, Wednesday, Thursday, from 2 to 5 p.m. Central Standard Time via Zoom. And the registration fee is only $299. The bootcamp provides overviews of key leadership competency areas developed and delivered by faculty members in academic health for early career faculty members in academic health. So with 9 contact hours, you'll learn about leadership principles that apply to yourself, in relation with others, and in complex organizations like ours. So this opportunity is open to early career faculty members in academic health institutions around the world. So please share with your friends. Let me tell you what the topics include. Overview of leadership competencies, self-knowledge and finding your voice, communicating for influence, difficult conversations and conflict management, organizational savvy, negotiating resources for yourself, promotion and career development, developing healthy academic habits, mentorship, This is on being a good mentee as well as being an effective mentor, resilience, and work-life integration. And we also have a panel presentation that closes off the 3-day session of 3 recently promoted associate professors in different pathways in different institutions. So you get to hear from them about lessons learned and hints they'd have for you to how to grow your career and get promoted. So again, it's 3 days, January 14 to 16, 2 to 5 Central Standard Time. It's only $299. To register, go to the facultyfactory.org website. It'll be on this podcast description as well as on the website. And I want to also run through the names of who our presenters are this year. Dr. Karma Fouché from the University of Illinois in Chicago, Dr. Rachel Levine, Johns Hopkins School of Medicine, Dr. Hannah Lundberg at Rush University Medical Center, Dr. Susan Matulavicius from the University of Texas Southwestern Medical Center, Dr. Elza Milona from Methodist University Cape Fear Valley Health School of Medicine, Dr. Bob Tillman at Baylor College of Medicine, and Dr. Valerie Williams from the University of Oklahoma. So we have a broad panel of experts. My colleagues and I, Dr. Susan Chubinskaya and Nutan Vaidya, are so happy to bring this faculty leadership collaborative. We're all going to be working together around the country to provide more boot camps, small, condensed, efficient Zoom platform to do some high-level overviews. We'll be doing a mid-career in April. So we hope you sign up and share this opportunity with your friends. Talk to you later. Thanks, everybody. Thanks for tuning in to Faculty Factory Podcast. The mission of the Faculty Factory is to build and support a community of leaders in faculty development who share tools, resources, wisdom, and encouragement in service to our faculty members, schools, and institutions. We encourage you to go to facultyfactory.org to find out more. Get in touch with me, ask me any questions. Maybe you want to be interviewed on the podcast. Thanks for tuning in to Faculty Factory Podcast. We'll see you next time. The Faculty Factory podcast and website is sponsored by the Johns Hopkins University School of Medicine Office of Faculty. For more information, visit facultyfactory.org.